A very good evening to one and all present here. I, Dr. Komal Lalwani, on the behalf of Nationwide Quality of Care Network, welcome you to today's Community of Practice session on collateral damage caused by COVID on health system. Now, I would like to call upon Professor Vikram Dutta to proceed today's session and introduce our speaker and participants for today's session. Professor Vikram Dutta is the Director Professor, Department of Neonatology, Lady Hardinge Medical College, New Delhi. He is a President of Nationwide Quality of Care Network and Vice President of National Neonatology Forum, India. He is a guest editor of PMJ Open Quality Journal. He is a member editorial board International Journal for Quality in Healthcare Communications. He is expert at the International Society for Quality in Healthcare. He is a lead national mentoring group and technical resource group lead, Sustainable Model for Lakshya by Ministry of Health and Family Welfare, India. He is a member of QED Working Group by Ministry of Health and Family Welfare, India. Over to you, sir.
Thank you, Dr. Komal. It's a pleasure to introduce Professor Sourabh Dutta. Professor Sourabh Dutta needs no introduction to this August gathering here today. Professor Sourabh Dutta is a professor of neonatology at the Postgraduate Institute of Medical Education and Research, Chandigarh. He's been a senior member of the National Neonatology Forum of India, a neonatologist and an academician par excellence. He's been trained formally in epidemiology in Canada and has been a visiting faculty to the McMaster University and has been facilitating multiple evidence-based research in the field of neonatology and a speaker par excellence. So we thank Professor Sourabh Dutta for taking time out from his busy schedule and attending to the call. A very important topic, which is about the collateral damage to the health system as a result of the ongoing COVID pandemic. Friends, as all of you are aware, the COVID pandemic has been raging for nearly the third year now, and multiple waves are coming. But the damage is directly, as of today, close to 6 million lives have been lost globally, and in US alone, 990,000 lives have been lost till now. Well, what we see as damage is the morbidity, the ICU stays, the loss of livelihoods, etc. But often the damage is far beyond that in terms of the damage which extends collaterally into the maternal newborn healthcare scenario and the gains which were achieved in the health system over the last 25 years of public health endeavors. So I'm sure Professor Sourabh Dutta is going to be discussing today in detail with special focus on neonatal aspects. What are the damages of COVID pandemic with special reference to neonatal healthcare, and how we can offset these challenges through concerted action in the times to come. So over to you, Professor Sourabh Dutta. Hearty welcome to NQOCN Southeast Asia Communities of Practice.
Thank you. Thank you very much, Professor Vikram Dutta, for that very kind introduction. Should I straight away get to the talk? Should I share my slides?
Sir, we can start with the presentation. Sir.
Yeah. Is it visible? Are my slides visible?
Yeah, it's visible, sir. You can go ahead.
Good afternoon, everybody, and welcome to this talk on collateral damage caused by COVID on the health system. And since I'm a neonatologist, I'll be having, delivering this talk with special reference to neonates. I will not be covering the broader economic damage caused by the COVID pandemic on human society and its indirect effects on newborn and maternal health, because that's a huge topic by itself. So I'll be covering other kinds of aspects, as you will shortly see. Now the issue is, what exactly does the word collateral damage mean? So collateral damage is damage other than what is obvious or directly being caused by COVID or any other agent for that matter. So interestingly, the word collateral damage was not used in medicine for the first time. It's a term that has been used in warfare, in the scenario of war. And the term collateral damage was actually first used in 1961 in the context of the Vietnam War. in an article by a US defense expert entitled Dispersal, Deterrence and Damage. And it attained considerable degree of notoriety, this term, because it became a catch-all term. So civilian deaths, damage to civilian structures, economic structures, etc., were all passed away as collateral damage. And there's always a danger that we may belittle the impact of either a virus or warfare by pushing everything under the term collateral damage. In fact, many of you may remember this iconic figure on the right-hand side, where the napalm bombs used by the US armed forces on Vietnamese citizens resulted in huge civilian losses. And this was a photograph of a girl who had been affected by the napalm bomb dropped on a civilian target. Well, once again, we are at war, except that the enemy now is unseen and unpredictable, has already come to us in at least 3 waves. And we are both the victims and the agents that are colluding with the enemy with our behavior. So let's see what all are the kinds of collateral damages that this virus is capable of. If we start from the top, 12 o'clock position, there are various obstetric indicators that the COVID pandemic has adversely affected. It has affected preterm births and stillbirths. It's adversely affected the performance of healthcare workers, the delivery of newborn care, emergency department visits. It has affected screening programs of various kinds in the newborn period. It has affected breastfeeding and the functioning of breast milk banks. It has affected post-discharge follow-up. It has interfered with vaccination programs. It has even affected the psychology of older infants after discharge, the psychology of mothers, the psychology of healthcare workers, and many other things. And I'll be touching about each of these in the course of my talk over the next half an hour or 40 minutes. And of course, there are dangers of problems occurring in future. That could it be the harbinger of future epidemics, and whether it could be causing dysbiosis affecting our microbiota, which is going to have an impact in future. So moving on, let us start with the first of these, and that is the worsening of obstetric indicators in India. So this was an article published by Vimla Kumari from Jodhpur in the Lancet in 2020, where they compared a 10 weeks post-lockdown period with a 10 weeks control period. And what they found was that the hospitalization of pregnant women had dropped by 43%. So that's a minus sign out there, minus 43%. The referral of obstetric emergencies had gone down by 66%. And this is, a setting in India, so it's very relevant to us. Caesarean sections had gone up by 12%. The proportions of illiterate mothers delivering in their setup had gone down by 5%, which means that underprivileged women were less often likely to come to a tertiary center for delivery. In-hospital maternal mortality had increased from 0.13 to 0.2%, which was statistically significant. Maternal mortality going up is a big deal. Stillbirths and IUFDs had increased, and that was also significant. There was an increased number of unattended and lower level facility deliveries occurring simply because mothers could not reach hospitals in urban areas. And the commonest reason quoted was lack of transport, leading to delayed arrival at hospitals. So this delayed arrival was also responsible for the increased mortality that they observed. This is data from Nepal, published in the Lancet in October 2020. They looked at institutional deliveries and found that they had declined in Nepal. They compared the first 22 weeks of the year 2019, when there was no pandemic, and corresponding weeks in the year 2020 when there was a pandemic, and they had a huge sample size of more than 20,000 births. So on the left-hand side, the graph shows 2019, right side 2020, and the vertical axis is the number of institutional deliveries per week, and on the horizontal axis, you have the first 22 weeks of the year. As you can see, there is a certain seasonal or temporal fluctuation that keeps occurring, that even in 2019, the graph goes a little up and down. But look at 2020, the lockdown started at week 12 and a half in the year 2020, And there's a, even before the lockdown started, there was already a drastic reduction in institutional births that had already started happening. And that got much worse after the lockdown compared to 2019. These are data from Japan, where they showed NICU admissions had decreased. So this is data on the left-hand side about the NICU, right-hand side, a special care unit. This was published in the archives in 2021. So the gray lines are showing 2019. The purple line is showing 2020. These are patient days of admission per week. And if you compare the gray line with the purple line, it becomes obvious that in 2020, from around the 10th or the 12th week onwards, there was a drastic reduction in number of NICU admissions and admissions to the special care unit. Again, so whether it's advanced countries or whether it's developing countries, the story seems to be the same. This is decrease in preterm births occurring in Netherlands from a population sample size of 1.6 billion singleton births. COVID control measures had been introduced from week 12 of 2020. And you can see that that preterm births gradually declined. This decline in preterm births has been observed all over the developed world. And as lockdown measures were became less, the preterm birth rate again came back to normal. Reduction in very low birth weight infants and ELBW infants was observed in Ireland. So on the left is VLBW, right is the graph of ELBW, and the axis shows all the years from 2001 to 2020, and you can see that there is a sudden change occurring in the year 2020, a big reduction in very low birth weight and extremely low birth weight infants in hospitals in Ireland. These are data from Nepal, where they found, unlike the Western world, an increase in preterm rate, stillbirth rate, and neonatal mortality rate. The sample size of 20,000. This is the same paper from the Lancet. So this is preterm birth rate, stillbirth rate, and neonatal mortality rate. The middle column shows the relative risk during lockdown versus before the lockdown. You can see that the preterm rate has gone up in developing countries. 3 is the relative risk, which was statistically significant. The stillbirth rate went up by 1.5 times, statistically significant, and the neonatal mortality rate 3 times, which was of course statistically significant in the lockdown compared to before the lockdown. So there could be different factors operating in developed countries versus developing countries. In the developing world, we are seeing increase in neonatal mortality and stillbirth rates. Okay, now what is the population level impact of the pandemic on neonatal outcomes? This was a meta-analysis of all studies that had been published until 2021. So the middle column shows the approximate sample size that was evaluated, pandemic versus pre-pandemic, and the right-handmost column shows the outcome, pandemic. So let's look at preterm births overall, what happened. Preterm births overall, you can see a huge sample size in this meta-analysis. The unadjusted odds ratio shows actually a decline in preterm births because much of the data is dominated by data coming from advanced countries. So they have noticed a slight decrease in preterm births. There is a difference between preterm births in national studies versus preterm births quoted from single center studies, with single center studies showing a greater decline in preterm birth. As you can see, preterm births after adjusting for covariates, after excluding COVID positive mothers, and preterm births less than 32 weeks, none of which was statistically significant, all the confidence intervals crossing the value of 1. When you look at stillbirths, again, non-significant overall in this meta-analysis. Low birth weight rate is also non-significant, and so is the neonatal mortality rate. But it is, the details, that means whether it is developing or developed countries, which is the real story of preterm births. Now, this is the impact, population impact of the pandemic, the meta-analysis in high-income countries versus low-income countries. And that's where the interesting data lies. So if you look at preterm births in high-income countries only, as I said before, there is a decline in preterm births, but there is a slight increase in preterm births when it's in low and middle-income countries. When you look at stillbirths overall, the stillbirths have gone up, and notice that it has gone up. I mean, there's a trend towards it going up, both in high-income countries as well as in low and middle-income countries. It is possible that some of the preterm births are not occurring because they're getting converted into stillbirths. That means the babies are actually dying in utero, and therefore they're not being born preterm. But this is a thing that still needs to be investigated further, this hypothesis. And of course, you can see here neonatal mortality overall between high income versus low income countries. There's not a great deal of difference. What happened to the performance of healthcare workers during the pandemic? This is again data from Nepal, looking at more than 10,000 healthcare workers. On the left-hand side is proportion of labors with optimal fetal heart rate monitoring. On the right-hand side, the graph shows the proportion of births after which breastfeeds were started within 1 hour. So these are two indicators taken as surrogates to see how well healthcare workers were functioning during the pandemic. And as you can see, the proportion of labors with appropriate monitoring, the proportion went down significantly during the pandemic, probably because healthcare workers were reluctant to actually touch or go too close to patients and talk to them and counsel them. Similarly, the proportion of births after which breastfeed started within 1 hour went down drastically in Nepal during the pandemic. For various reasons, behavioral factors, the fear factor and lack of healthcare workers, because some of them may have been redesignated to COVID areas, whatever may be the reason, the performance went down. This is a survey looking at the impact on newborn care in low and middle income countries. This is a global survey, 1,120 responses from 62 countries, mostly low and middle income countries. This was published by Dr. Suman Rao in 2021 in the BMJ. Now let's see what are the changes that happened in newborn care across the world in low and middle income countries. So newborn unit admission capacity reduced occurred in 37% cases. Newborn unit or KMC staff getting reallocated for COVID-19 duties, all of us are familiar with this problem, occurred in almost a fifth of centers. Babies discharged earlier than usual, 44% cases. Families refusing to stay in hospitals that are COVID treatment areas, again, a familiar story to us, almost a third of cases that happen. Healthcare workers hesitant to promote KMC, 24%. Families hesitant to practice KMC because of the fear that, mother may transmit something to the baby, 17%. Fewer follow-up appointments for newborn infants, almost half of the cases this was seen. Families reluctant to attend follow-up due to fear of infection, very prevalent. So almost 3/4 of families were reluctant to, come for follow-up. Telephonic phone visits in 37% of cases. So there's a huge impact on newborn care in low and middle income countries. What happened to emergency department visits in developed countries? So there was a reduction in ED visits seen. So this is data from 2020. The light blue bar is the comparison period. The dark blue bar is the early pandemic period in the US. And let us focus, and the horizontal axis shows the age group. So let us focus only on infants and children, which is the leftmost bars. And you can see how much the emergency department visits went down. So that means even when kids were having problems, parents were reluctant to bring them to the emergency department and preferring to do some home-based therapy or consult their local family doctor or whatever, which would have, of course, affected a lot of outcomes. This is the impact on ROP screening in the epicenter of the pandemic in Wuhan, China itself. This is data from there, published in 2021. The light blue line, starting from the bottom, is 2020 data. The darker blue line is 2019 data. And these are the months of the years 2019 versus 2020, starting from February going up to October. So you remember that in most parts of the world, the pandemic, hit us in March. In China, it was already very prevalent in, February. And On January 23rd, there was a lockdown in Wuhan. 8th February, they were out of lockdown. Now see how badly ROP screening got impacted in Wuhan, China. In February, they did not screen a single baby. In March, only 25 compared to what they would have, screened in 2019, 67 babies. And this gap between the number who should have been screened and number who are actually screened went on, and it gradually improved till it normalized somewhere in October. So screening programs in neonates were badly affected. There was also decreased screening, ROP screening observed in an advanced country, in Massachusetts in the US. So this is 2019 versus 2020 data. The total births and the total number of births less than 31 weeks were comparable. But look at the number of ROP exams performed. In 2019, 280, that dropped to 228 in 2020. Infants screened, outpatient infants screened from 70 came down to almost half. Number of ROP exams, outpatient screened, again decreased by more than half. So even, advanced countries were affected by this pandemic in terms of screening programs for neonates. What about breastfeeding? So these are the factors that affected changes in breastfeeding practices after lockdown in Thailand. It is published in 2021. So in this study, they defined change in breastfeeding practices as change from either exclusive breastfeeding to either mixed feeding or reduced feeding or stop feeding. So that was considered a change in breastfeeding practice. So they had two groups, those which had changes in breastfeeding practices, those that did not have changes in breastfeeding practices, and then they asked the mothers why they changed their breastfeeding practices. So it can be seen that household crowding after the lockdown, that means not getting enough privacy to breastfeed, 28% reported that in those who had changed their feeding practices, whereas only 14 in those who did not change their breastfeeding practices, which is statistically significant. Family stress from confinement amongst those who changed breastfeeding practices reported in 10% versus only 3%. Lack of family support, 10% versus 1%. Did not get lactation support from a healthcare worker because of difficulty in approaching hospitals and so on. 23% reported amongst those who changed their feeding practices versus only 7% amongst those who did not change. And so on. All of these are statistically significant. What are the challenges faced by human milk banks? So this was a review published in the journal Maternal and Child Nutrition. So this was a virtual collaborative network that was formed soon after the pandemic, and they collected experiences from milk banks across 35 countries. In fact, Dr. Vikram Datta's unit was also involved in this, their milk bank in Lady Hardinge Medical College. So they identified 7 pandemic-related vulnerabilities. Firstly, donor human milk availability. There was an increased demand due to concerns about spread through breast milk, and donors were unable to access milk bank. Second, there were difficulties related to pre-screening for COVID-19 exposure in milk donors, and that decreased the number of donations available. Donors got dissuaded by the whole logistics of serological screening and everything that had to be done before donating milk, so they thought they were anyway doing people a favor by donating milk, and they didn't want to go through all the logistics of screening. There were difficulties in communication between human milk banks and potential donors, trying to reassure them and so on. Milk collection and transportation problems were there because of milk quarantining, having to screen the mother, wait for those reports, etc., social distancing issues. Donor human milk handling, there was a lot of exaggerated concerns about infectiousness of human milk in the beginning of the pandemic, before we all got to know that there's hardly any spread through human milk. But by the time, a lot of the damage had been done. Mothers whose babies were to receive milk as well as donors who were to give milk, both were concerned about human donor milk. And there was lack of contingency planning for extra staff. Many staff got withdrawn for COVID-related duties, and milk banks got into trouble. Okay, what happened post-discharge, high-risk neonates? How did the pandemic affect them? This is data from the US, Duke University, comparing March, April, and May of last year. The blue sections of these bars were in-person follow-up visits, orange is telephonic visits, and gray is video post-discharge visits. As you can see, March fairly unaffected. By the time you come to April and May, most of the in-person visits have become almost negligible, replaced by either telephonic or video visits. As people became more and more familiar with technology, this is what happened. So what they found, these authors found, was that the restriction on visitation, because most hospitals develop very stringent visitation policies of family members and mothers, it made mothers and family members less trained to look after neonates after the babies went home. There was a heightened social disparity in access to healthcare. And the digital divide between the haves and the have-nots, technophobia, English proficiency, all heightened the social disparities that were already there, because the haves were still able to access healthcare, the have-nots were not able to. And infants with complex health needs and multiple specialty needs were even worse affected than others. This is the experience from the Children's Hospital of Philadelphia, which they published in the Seminars in Perinatology last year. They looked at the challenges of telemedicine in NICU follow-up. You know, all of us have been doing telemedicine NICU follow-up some way or the other. And these authors, they actually put it down in black and white, the experiences that they had and the challenges they faced. So one of the challenges was that neurodevelopmental tools for telemedicine are not yet validated. So they were kind of, making the mother or family members do certain, things on, say, a video call, but they were not really sure whether this was a valid way of doing it. Now, many tools actually require the child to directly interact with toys and, red ball of wool, ring, and so on, none of which was possible when it was a telemedicine follow-up. There were a lot of internet connectivity issues, even in a developed country like the US. And they, on a humorous note, they say that for a single parent to hold the camera focused on the child and provide developmental stimuli is difficult. And I'm sure all of us have faced this. So in the paper, they say our providers have spent considerable time observing floors, ceilings, lamps, and shoes rather than the patient, because the camera was pointed in some other direction. There was also difficulties noticed in focusing on clinical problems, because it's easy to do that in a hospital environment, difficult in a home environment. So distractions inherent to the home environment, such as interruptions from siblings, pets, doorbells, and telephones, sometimes prolongs or even completely derails the clinical encounter and makes it a completely non-serious affair, which has really affected NICU follow-up. Scheduling and coordinating multidisciplinary teams becomes very difficult when it's being done online. What was the impact on infant vaccination? Well, in a nutshell, infant vaccination declined in the US as well as everywhere else in the world. So this is population-based data. The blue bars, vertical bars, is 2019. The red bars is 2020. And these are the number of vaccine doses administered. There was a national emergency declared in the US on the 13th of March 2020, where I put this arrow, and you can see immediately vaccination rates plummet. And it takes several months before it comes back to somewhere near normal. What was the psychological impacts among healthy infants and very preterm infants and infants with congenital heart disease on follow-up? So on the left-hand side is pre-COVID data, right-hand side is the COVID period. You can see that whether it is a healthy control infant or a preterm infant or infant with some surgical problems like congenital heart disease, everywhere the psychological well-being score declined. The impact was felt much more by preterm infants who were, had grown up, to, preterm neonates who are now grown up to become infants in the second or third year of life. The impact was much more during COVID. What was the impact on mothers regarding postpartum depression? There are a number of studies regarding this. The incidence of major postpartum depression was higher among the mothers of preterm infants delivered during the COVID pandemic because of all the stress of delivering during that period. So 26% compared to the control group, which was statistically significant. And after adjusting for confounding factors, birth during the COVID pandemic period was an independent risk factor for major postpartum depression. So it itself became a risk factor. Adjusted odds ratio of 3.6. What about its impact upon healthcare workers? The impact upon the psychology of healthcare workers. This is data from India, so we can all relate to it. Published last year. These are anxiety scores. There's a particular scoring system that they used. So they found severe anxiety in 7% healthcare workers, moderate anxiety in 12.5% healthcare workers. And almost everybody had some degree of anxiety or the other. Poor to fair sleep quality, poor sleep quality in about a third of patients, a third of healthcare workers. And this has been very widely reported, not being able to sleep well. And female gender and inadequate availability of PPE was significantly associated with higher anxiety levels. And there are certain other factors associated with sleep disturbances mentioned here. This was a survey on the psychological well-being of specifically neonatal healthcare workers in the US. So there was a survey of 288 maternal and neonatal healthcare workers. The majority were nurses and had been working for quite some time in their current position. So it's very interesting what they have reported. They reported 12% reported increase in medical errors during this pandemic period compared to before. 33% more unprofessional behavior on their own part and the part of their colleagues. More than half found it difficult to focus on their work. Almost 60% found it difficult to meet home and balance it with work responsibilities. 75% noticed increased burnout amongst colleagues during this pandemic period, and 66% reported emotional exhaustion. Compared to doctors, nurses had significantly higher concerns regarding several of these phenomena. This is the result of a systematic review and meta-analysis on depression, anxiety, and post-traumatic stress disorder in healthcare workers. So it includes a sample size of close to 100,000 healthcare workers across 21 countries and 65 included studies. The outcomes here are moderate and mild depression, anxiety, and post-traumatic stress disorder. So the pooled prevalence of moderate depression among healthcare workers was as high as 22%, with subgroup analysis showing difference between different parts of the world, higher in the Middle East, for instance. Mild depression was found in a huge number of, so I was talking about depression, anxiety, and in approximately a fifth of all healthcare workers, in a nutshell, in this systematic review, had problems with anxiety, depression, and post-traumatic stress disorder. Okay, now the interesting thing noticed during this pandemic was that other viral illnesses decreased in the first year of the pandemic, when we were all busy doing the right things, wearing masks, hand washing, maintaining social distancing with great fervor. There was a decrease. So on the left hand side is data from Italy regarding RSV, right side is flu. You can see the months and years in the x-axis, and notice that every year in winter there was an RSV outbreak and a flu outbreak, which completely went missing from November 2020 to January 2021. Now that brings us to the concept of immunity debt. So this is a statement that I've taken from the Pediatric Infectious Disease Group position paper published in 2021. So this is an international group, and what they say is the lack of immune stimulation due to the reduced circulation of microbial agents and to the related reduced vaccine uptake induced an immunity debt which could have negative consequences when the pandemic is under control and precautions such as mass social distancing, etc. are lifted. The longer these periods of viral or bacterial low exposure are, the greater the likelihood of future epidemics. This is due to a growing proportion of susceptible people and a declined herd immunity in the population, the observed delay in the vaccination program without effective catch-up, and a decrease in viral and bacterial exposures, routine exposures that we are all accustomed to. It leads to a rebound increase of vaccine preventable diseases. Now, is this going to happen? Well, it's already happening. And I've put the term revenge epidemics, like how we talk about revenge tourism. So the revenge epidemics due to RSV have already started. Look at this data from Japan on the left-hand side. So there are these various lines, the corresponding to different years. The lines I want you to focus on are the 2019, 2020, and to the 2021 line. So which is the 2020 line? The 2020 line is the flat one, absolutely flat one at the bottom, showing no RSV in 2020 in Japan. Which is the 221 line? It is the dotted line which is shooting up. And at the time of writing this paper, the full 2021 data, in fact, were not even available. And look at the comparison. There's a virtual epidemic of RSV in Japan right now. Similarly, look at data from Australia published in the archives. 2019, the usual number of RSVs. 2020, no RSV. 2021, already look at the way it is shooting up. I mean, towards the end of 2020, December, and after that, beyond 2021, it would have gone up even further. Next question is the COVID generation going to be dysbiotic? Is it going to affect the microbiota? There's a real worry that it is going to create problems with our microbiome. Normally what happens, that's shown on the left hand side. Normally there is, we do delayed cord clamping. Most deliveries are vaginal. There is immediate skin to skin contact. KMC is encouraged and actually practiced. Breastfeeding is not affected. So breast milk microbiota gets into babies. Visitors are allowed. Social gatherings do happen. Physical interaction does take place between family members and babies. And you maintain just the usual kind of hygiene and sanitation. You don't go overboard. What's happening now during the COVID-19 pandemic? Cord clamping, delayed cord clamping is being avoided by many people because they want to separate the mother from the baby. Cesarean section rates have gone up. Skin to skin contact rates have gone down. KMC is not being encouraged as much as it was. At least, this was what was happening in the initial phases of the pandemic. People are a little wiser now. There was less breastfeeding, and especially in the initial months of the pandemic. And there are definitely less visitors, less social gatherings, physical interactions, and excessive and almost obsessive hygiene and sanitation is being maintained. And all this may affect our microbiota. And what effect is going to have on allergic diseases, cancers, etc., in the decades to come, God alone knows. So my take-home messages from this talk are that the COVID pandemic has resulted in less institutional births, increased preterm and stillbirths in low and middle income countries. It has resulted in less preterm births, but more stillbirths in high income countries. It has resulted in many difficulties in administering neonatal care, including adequate breastfeeding and KMC. It has created hurdles in the functioning of human milk banks, resulted in lower vaccination rates. It has interrupted ROP and possibly other screening programs in neonates. It has definitely made post-discharge follow-up difficult. It has resulted in increased psychological problems for healthcare workers, mothers, and even ex-preterms who are on follow-up. And we don't know what this, we have to watch this space. The pandemic may actually spawn future epidemics of other viral illnesses and create totally unanticipated problems due to widespread dysbiosis at a community level. So thank you very much. With that, I end the formal part of my presentation and would happy to join in the panel discussion or take any questions. Thank you very much.
Thank you so much, Professor Sourabh Dutta, for that excellent rendition. In fact, I have happened to witness it twice. In fact, the first time I could hardly get 50% of the messages because there were so many messages. And this time we have been updated with the 2021 data as well. to the presentation. And sir, I believe that certain aspects which are hardly discussed, like the aspects of the dysbiosis, the aspects related to the healthcare worker psychological safety and the psychosocial well-being, as well as the anxiety and the depression, and the aspects related to the resurgence of the infections which were in control because of routine vaccinations and exposure, like the RSV, the increase in the RSV rates or something, which are beyond. And this, I would say, is the collateral aspects beyond some things which are very, very obvious. So with this, I'm very happy to welcome here Dr. Shams Syed from WHO headquarters. Dr. Sourabh, when you were not there, I had already welcomed him, but he heads the quality division at the WHO Geneva headquarters, and we are very happy to welcome him here. And we are also proud to welcome Dr. Rajesh Mehta and other colleagues from National Neonatology Forum and NQOCN. So with this, I will open the session for discussion with the panel and open it for Q&A sessions. So we have a question. First, I will take the Q&A and then I will go to the panelists. So we have a question from Dr. Reema Nagpal. Dr. Reema is faculty at the BJ Medical College, Pune. Dr. Reema wants to ask you, Dr. Sourabh, has there been any reported increase in neonatal bacterial sepsis during the first and second waves? And if it is there, what are the possible reasons?
That's a very good question. In fact, I would request you to wait for a few weeks, because there is a paper that of ours from PGI, which has got accepted for publication in the Pediatric Infectious Disease Journal, and it should be getting published soon, where we compared data from March to September of the year 2020 with a corresponding period in 2019 and a corresponding period immediately prior to the pandemic. So there are 3 periods that we compared, and we showed that there was a huge reduction in neonatal sepsis, in hospital neonatal sepsis. And what was very strange is that it affected certain species more than others. So Acinetobacter baumannii, which was a big problem in our center, multi-drug resistant Acinetobacter, virtually disappeared after the lockdown. And it was not simply because of overall decrease in sepsis or decrease in number of admissions, not just the absolute number, even as a percentage. And even after adjusting for various covariates, we found that sepsis, especially multi-drug resistant Acinetobacter, drastically declined in our center. And in casual conversations with people across the country, we found that many people have had a similar experience. So there could be, it's multifactorial. Certainly a number of deliveries went down, institutional deliveries went down in many centers. So there was less overcrowding, especially in public hospitals in the labor rooms. It was easier to keep neonates for a longer duration in the appropriate areas, whether it's the NICU or the step-down care area, without having the pressure of beds or having to discharge babies prematurely, because suddenly there was a luxury of more beds available. And of course, there was this heightened focus on hand hygiene, maintaining social distancing, your environmental cleaning. There were protocols set in many units for disinfecting, doorknobs, telephone sets, etc., fomites. So all this actually played a role in decreasing, not increasing, bacterial sepsis in hospital settings. I cannot say what happened in a community setting. We haven't studied it, but this is an interesting finding, and we are reporting it soon.
So, Dr. Sourabh, I think this is an excellent observation and a very plausible explanation which you have given. I would just like to very briefly add the findings from one of the DM theses which have been done on quality improvement and just submitted to Delhi University a couple of days back from one of our students. He studied at the rates of late and early onset neonatal sepsis, and surprisingly, during the last 2 years, that is over 2020 and 2021, we have noticed in the neonatal ward of Kalavati Saran Children's Hospital a marginal increase in the early onset and a total sepsis, if I pool it with late and early onset. The various special causes which we attributed to it was a severe resource crunch. And then there's a lot of mothers who are coming because Kalavati Saran Children's Hospital was receiving a lot of unbooked mothers, because most of the hospitals in Delhi had become, COVID hospitals dedicated. And most of the women were coming for deliveries directly, walking into the labor rooms in advanced stages with lots of leaking, unbooked, multiple PV examinations, and lots of infections. So we were getting a lot of infected babies, plus there was resource crunch. And we also surprisingly saw an increase in the antibiotic usage rate also during these periods. And I don't know whether all of these special cause factors, what we did a statistical analysis, we found that there was a marginal increase from our center. We've just submitted it as a DM dissertation. So this is just slightly contrary to your observation. Yes. But I believe that there comes the importance of context and why people should share at the national level their experiences.
I'm sure the dynamics of each unit would be very different. And local factors would really be playing a role in all these phenomena.
So thank you so much. I think there's a Dr. Shams would like to, he's just mentioned. Dr. Shams, if you're around, sir, can you unmute yourself and put up your comments, sir? We would be very happy to hear it.
Yeah, thanks so much, Kram. Just congratulations on all the work, and I apologize for not having been here from the beginning. Just I was curious to hear your thoughts related to the role of compassion in facilities and between workers and in managerial efforts at the facility level, and also management in districts. It's of course very much related to the issue of mental health, and how compassion can be almost an intervention that can take the edge of some of those mental health issues. There has been some exploration on this one, but I'd be very curious to hear whether there's been any experiences related to injecting in the compassion lens into these very, very difficult situations. Over Dr. Vikram.
Yeah, thank you so much. So over to you, Dr. Sourabh. Compassion in the current times and how it can help in mitigating the effects of mental health issues in the pandemic.
In fact, I think somebody should do a study comparing mental health issues between the different waves of the pandemic, because I think our own attitude as healthcare workers towards this problem has changed over time. I know the amount of fear, exaggerated fear there was during the first wave of the pandemic, when we didn't know enough about this disease, which got even worse during the second wave in India, where mortality rates were very high. Patients were all getting admitted with need for oxygen, dying because of a non-availability of oxygen. And I can see the difference with the third wave, which we're currently going through, the Omicron wave, where we've recognized that it's much milder than previous waves. And in fact, most patients getting admitted in PGI now are actually not getting admitted for the COVID related problems per se. They're getting admitted for other diseases and being incidentally detected to have Omicron on a routine test. And frankly, more than 50% of our staff, I think, have developed COVID during this wave, including yours truly. And the attitudes have actually changed because of this feeling that the current strain is a lot less severe than the previous strains. So I think there was really a need for a lot of counseling, proactively acknowledging that healthcare workers are going through stress and mental health problems, reaching out to them. I think that there was really a need for that, especially during the first and the second waves. And unfortunately, most hospitals did not really put in such structures in place, where healthcare workers could seek help. People could proactively counsel them and assuage their fears and so on and so forth, because we were so busy firefighting and managing the pandemic. But I can see that a lot of those issues have actually come down now in this third wave. those mental health issues amongst healthcare workers. In fact, sometimes I'm worried that healthcare workers are probably taking it too casually in the current wave that we are currently going through. Yeah, so that's what I have to say. Dr. Vikram, would you like to add something?
No, definitely, sir. I think we would like to share the results. I think WHO and UNICEF India had supported a large survey which NQOCN India had done, and we had intensively, conducted in the month of October, November 2021. We had initiated a series of workshops, capacity building sessions, and sensitization sessions across the healthcare worker teams to identify and tackle the ongoing psychosocial issues which are happening, including the hidden element of depression and anxiety. And as a part of this, we ran a survey which was done across the nation. And I would be very happy to invite Dr. Rahul or Dr. Sushil, and they will be just briefly mentioning. And we were very, surprised that a large proportion of the results returned people suffering from depression, like 21% you said in the systematic meta-analysis and the review which we saw, the pooled. Here, Rahul, can you just briefly show the results? Yeah. Can you just take us through? Yeah, Sushil. Right. Thank you.
Yeah, I think, Rahul, would you like to go through these findings, which we had, as Vikram rightly pointed out, we had conducted a quick survey using a adopted tool from WHO and psychiatric associations. And we had very surprising findings. Rahul, please, would you like to go through the key findings? Yeah, thank you.
So thank you very much. So the brief survey that we ran for about 4 weeks duration, 3 weeks duration, the findings were approximately 30% of the healthcare workers who took part in the survey reported depression during the 2 weeks prior to the survey. So that was defining criteria. And when we compared it with the National Mental Health Survey findings, so it was significantly higher. Similarly, psychological stress was reported from staff from government hospitals and medical colleges, around 25 to 30%. Staff from medical college experienced 18% less prevalence of moderate to severe depression and 23% less prevalence of mild depression compared to staff from government hospital. So we were wondering as to why this variation could be, because the staff from government hospitals at district levels reporting higher incidence of higher prevalence of moderate to severe depressions. Similarly, psychological stressors faced by healthcare workers, especially frontline workers, overall, it was mentioned that they were increased, and these increased stressors could precipitate. So these are our derivations that these could precipitate mental illness amongst healthcare workers, especially during these stressful times. And these were the key recommendations that we came up with to establish a robust psychosocial support mechanism across the health system, and especially build the capacity for training and resilience for healthcare teams. So if Dr. Sushil would like to add more. Yeah.
So just to add what Dr. Rahul presented, and if Dr. Vikram and Dr. Sourabh allows us, are that yes, a lot depends on the contextual factors also about the degree of fatigue and system, you can say, robustness and weakness to see the effects of COVID pandemic and post-COVID pandemic. And just to share that the level of psychosocial stress or your depression and anxiety was relatively little higher in your private sectors as compared to the government or public sector, but it was not statistically significant. And secondly, sharing the learnings which we had in our tertiary care teaching hospital has been that we are trying to collate the data. But yes, post-COVID pandemic scenario also is throwing up a lot of surprises. And the surprises are in form of, yes, we are getting complicated cases, unbooked cases. The culture profile of our routine microbiological survey of our NICUs and patient septicemic culture data is showing a very dangerous shift. I don't have exact data right now to share. We are analyzing the data, but we are isolating multi-drug resistant gram-negative organisms much more if we compare to our last 3 pre-pandemic data. One. Secondly, the routine, your bad bugs of the NICUs, as Dr. Sourabh rightly pointed out, Acinetobacter baumannii and others are less. They are not there much. We have also seen some degree of fatigue and you can say a little apathy among healthcare workers. And it's not only nurses or paramedics, but also doctors. And the reasons are a little difficult. They go beyond your routine work profile and work responsibilities, as most of these doctors and nurses, more so in pediatric and neonatal area, have been catering to adult areas. Their work profile and rotation was very frequent. They had been taxed and are now back. They are still finding their ground. Lot of dilution has happened in terms of skill and you can say capability requirement of particular critical areas because of severe manpower pressures. People have been rotating a lot, and that has put pressure on our hospital. So I think, Dr. Sourabh, just to be brief, very important insights. And I think more is yet to be analyzed and to come. And as healthcare workers and professionals, empathy and psychosocial safety or support, not only for our patients, but also for our healthcare workers, is the need of the day. And maybe we will all be have to working toward it. Thank you. And sorry if I took a little long. Yeah, thanks.
Thank you so much, Sushil, for sharing those insights, and Rahul for very quickly sharing the results. We are in the process of publishing the same results done over wide parts from nearly 90 plus cities across India. Dr. Rajesh Mehta, sir, quickly your comments, please.
Yeah, thank you. We have discussed at length the caring of carer issues, but thanks to Shams, the compassion is not just for the carers. We are in the business of healing. Compassion should be the focus for all healthcare services because people deserve compassion along with antibiotics. So this also was kind of challenged, as Sourabh also mentioned that doctors, nurses themselves were quite scared of the virus in the first phase. They didn't want to get close to the patients. So the patients who were deservedly admitted in hospitals did not receive attention. Even from the paramedics, a glass of water would be difficult to get for a patient because no people are getting, scared to get into the room where COVID positive patients are there. So this is a great reminder, the pandemic, that compassion should remain the centerpiece in our business of healing, not just for our own selves, but also for the patients who deserve good quality care from all of us. But also there are issues related to, thanks Shams for that, raising that issue. And this publication he has pointed out would be good to go through. It's a quality issue, compassionate healthcare. And also importantly, taking forward what Sourabh has been, he gave us a very good summary of how we suffered together in this professional, discharge of our duties. And he mentioned that neonatal mortality has not increased. Although with the interruption in services, we had all expected that the mortality trends would show up because there may be risk of additional mortalities because of interruption of services, and a lot of modeling which was done using different tools did suggest that we should be prepared for additional mortality. But the data shown by Sourabh suggests neonatal mortality continues to decline. Even the UN IGME estimates of 21 report, which was released end of the year using 2020 data, which is part of the pandemic year, there is continuation of decrease in under 5 mortality in all countries, whether they had big waves or small waves. So there are, some analysis required. There is a clear possibility that communicable diseases may have gone down. As Sourabh was mentioning, our hand hygiene, social distance, protocols of ICP, infection control and prevention protocols in hospitals getting better, social measures getting better. Then mask may be preventing pneumonia, childhood pneumonia seeking. Sourabh and Vikram and everyone knows the hospital utilization rate for childhood illness like pneumonia, diarrhea went down. significantly. Nepal showed 50% drop, and it took longer time to recover. Recoveries did take place. That might be, explanation that child mortality did not get increased. Maybe there was a drop in services, but quickly recovery happened. Immunization recovered much faster. But maybe the mask prevented some airborne bacterial infection for pneumonia. Who knows? We have to understand that. Then pollution did decrease because of lockdown. In Delhi, we saw clear blue sky after a long while during lockdown. So mask itself tackling the pollution, air pollution, the air pollution going down because of poor decreased industrial activity. Injuries went down, and injuries are becoming epidemiologically a good, higher proportionate cause of mortality in childhood, especially later childhood. So all of that may have contributed to decrease in mortality, while indirect effects would have pushed it up. So in the net effect, we haven't seen anything yet. But some of the long-term effect, Vikram, of increasing poverty and inequity because of the pandemic, food insecurity getting more and more, leading to some additional malnutrition component in childhood. We still need to observe whether these long-term effects would further, push the mortality up a bit in the next estimates of UN agencies. But by now, 21 report, 2020 data, it doesn't show. But we should be prepared to analyze more and expect that long-term effects might also. And before I end, Shams is here. I want to also have a provocative observation. We must consider, actually, before pandemic, were we over-treating our patients? Are they better off remaining outside hospitals? I think there is a case to investigate this. So many stents were not put in coronaries and all over the world, and many interventional procedures, and we didn't see additional mortality because of the coronary events, although mortality happened because of infection itself in that population. So I think we need to look at the over-medicalization part of the business in which we are. If not now, when will be the opportunity? Over. Thank you.
Thank you so much, Dr. Rajesh Mehta. In fact, I think multiple points you mentioned, and the last point is something which keeps on going in our minds also, that despite, very intensive involvement, is it sometimes that the involvement with the health system and the errors of the health system, and as most of us are working in the field of quality, and Dr. Shams is also here, we all know that nearly 5 million people globally are losing their lives when they come to the hospital to get treated. Maybe these are the people who've probably escaped, dying from the maladies of the health system. And this is rather a provocative statement. I know I have no evidence to say that. I'll quickly invite a comment from Professor Sourabh Dutta on these aspects.
Yeah, I mean, the last point that Dr. Rajesh Mehta made was very interesting. It reminded me of, there are some 3 or 4 publications about patient mortality, not just neonatal, hospital mortality, when doctors went on strike. So what happens? And the funny part about it is that mortalities uniformly across the study show that it declined when doctors went on strike. I had once used this data as a humorous point to support me in a debate, but it may well be that a lot of medication errors, adverse effects of drugs, post-operative mortality, because obviously during doctor strikes no surgeries took place, so you couldn't die of a surgery if you didn't even undergo the surgery, and etc. They may have gone down. So it is something which is worth looking at, and trying to maintain these levels of hand hygiene and maybe wearing a mask inside the hospital, keeping it as a routine, even after the pandemic finishes. It can't do any harm. It can only do benefit to our patients.
So I know this has been an interesting discussion. If Dr. Sourabh allows me 3 more questions, one from Dr. Praveen Venkatgiri.
Sham's hand is up, Vikram.
Oh, I'm so sorry. Yeah, Dr. Shams, please go ahead.
Not just, it's always good to have Rajesh make some provocative statements, because it's important to discuss, not focusing in on the intricate details of neonatology because the experts are in the room, but overall, if we are to design future health systems, then of course we do need to carefully consider people-centered services that move away from the institutions and think about designing those services based on people rather than diseases. And the point that Professor was just making related to institutionalizing hand hygiene, that's just a classic example of something that has high impact, is evidence-based, and can have clear outcomes in even the shortest of terms. And nothing speaks better than clear data on improvement and outcomes. And the more that can be institutionally focused rather than particular diseases or particular population groups, then we have something to say. So Rajesh, as always, it's good to provoke us, and bringing in the human side here. Compassion has a part to play in that as well. Sorry to take up time, Dr. Vikram.
Very aptly said, sir. Thank you so much for bringing in the element of compassion and the human factors. We would definitely like to explore them further and take it forward. And they are undoubtedly linked to the aspects of quality of care. So I think it's central to the theme of any equality.
I may just indicate the link in the chat. Please do share your experiences from the field, because your wisdom is what's going to change things. Okay, so I just wanted to make sure. Thank you so much.
Thank you so much, sir. So over to you, Praveen, for a quick question.
Yeah, thank you. I mean, I had put in a question, Professor Dutta, regarding, yes, we know what problems occurred beyond the COVID, but there are many things which have happened which has helped, to treat the COVID, and despite the COVID, to run the system as well. So what are the learnings or from that kind of thing, which is mainly leadership and system wise? Like one is what you mentioned about the hand hygiene. You know, we try to implement, it is so difficult to implement, but during the COVID times, I'm sure everyone followed that. So what are the learnings, or are there any kind of strategies that we can implement from this journey? Positive things.
I think there are several positive takeaways. I mean, this pandemic has taught us a lot, including how to conduct online meetings like the one that we are conducting right now. I mean, none of us knew ABCD about conducting online meetings, and now there are meetings with thousands of people participating, and people sticking to rules, knowing when to mute themselves, when to unmute themselves. All those etiquettes have also become part of our psyche now. Secondly, I think the pandemic has really taught us how to organize ourselves. I think all hospitals were forced to get their act together, vacate wards, create entirely new facilities which they had never read about, heard about during their medical training, and they managed to do it within a span of weeks, at the most a month or a month and a half. And we now know that if we ever face such a problem again in our lifetime, we'll know exactly what to do, because we've gone through it before. Another tremendous thing I think which has happened in India, I never expected that at such a mass scale we as a country would be able to manufacture PPE and distribute it to everybody. I mean, it's PPE and N95 masks are all over the place now. I remember in the first couple of weeks we were struggling to get these things, and now it's in abundance. And it's truly extraordinary how this has happened, and it's all happening indigenously. It's not that as though we are importing it from some other country. And of course, the vaccination story has been in India has been a huge success story. So I think our ability to get ourselves organized within a short span of time in the face of adversity, at a macro as well as at a micro level, down to the unit level, our ability to leverage technology to communicate with each other, not just these online meetings with our patients and so on. even patients have got used to, doctors now making a WhatsApp video call, and then they'll turn their camera towards their baby and they will show us how fast the baby is breathing and so on. Even they have learned in the process of how to send across data. So I think some of these are huge positive gains, if I may say so, within quotes, from the pandemic. Of course, we would have been better off without the pandemic, but there are many silver linings to the pandemic. Thank you.
But we should not fail in memory terms. We should use this all positive learning for better preparedness. The human memory is short, the public memory is even shorter. So I think we must build upon better, much better than what we were prepared. There is no shortcut there. For example, you said PPE, masks. How are we disposing them? There's a huge challenge on the ecology and the environment, that these are not degradable stuff, and how do we dispose them off so that we don't bring harm to the environment? So our Director General WHO brought this back to notice, that it only underlines our underpreparedness as a system to deal with biomedical waste. So we let us be better prepared for the next time, and consider that we are in emergency perpetually, and then perform at the highest level.
I'm sure, Dr. Rajesh Mehta, you very rightly mentioned, like any act of improvement, like Professor Sourabh Dutta has mentioned, the quick manufacture of the kits has got an offside to it, or a downside, like we say in quality improvement, a balancing indicator, and that is how we are disposing it, and the risk of cross-infection. And that has been the observations in most of the places. The PPEs lying scattered, the rack pickers picking them up, people just recycling them sometimes and repackaging them. So these are issues which are very right, but I think it is a step in the right direction, and it will take the system to understand that the steps have been taken, and more, system preparedness will be required to make them more robust, and the balancing indicators will have to be taken care of. So I have one last question I would allow. If we have Lieutenant Colonel Meenakshi, if you could unmute yourself, ma'am. Your hand has been up for quite some time now. Lieutenant Colonel Meenakshi Devi Sharma, if you could unmute yourself, we are allowing you to unmute yourself, ma'am. Okay, so Sunita Chandran, there's another question from you, ma'am. If you could unmute yourself. I think there's some communication issue with both these participants. Okay, so one last question is again from Dr. Rima Nagpal. Dr. Rima, if you are around, you can unmute yourself. Otherwise, I will be just reading the question. Dr. Rima, you can unmute yourself, please. Can you unmute? Yeah, Dr. Rima, yeah. Please go ahead, ma'am.
Sir, I just wanted to find out, has any study been done where, all the NICU admitted babies for non-COVID reasons, I mean, they were admitted for some other reason, have they been tested and found their COVID status? I ask this because so many of the healthcare workers have fallen sick. These babies are intubated, they are without masks. So I just like Dr. Datta's opinion on this.
I don't have any definite data about this. I haven't come across anyone doing, a survey on all neonates being admitted in a unit. But I don't know, Dr. Vikram, do you have any such information? I mean, mothers have all been tested because that was a part of the national policy. But after that, and we have assumed that the mother was negative, the baby would be negative at least at birth. But I think your question, Dr. Nagpal, is that would the babies have acquired it subsequently during hospital stay?
Yes, sir,
from healthcare workers? Yes. I'm afraid I don't have definite data about that.
Is there birth in something like that? I'm asking because we assume that.
I'll just like to add. So we did do in the first wave pandemic, and even in subsequent wave pandemic, we were tracking the newborn babies who were otherwise okay. And because of the online follow-up also protocol, we kept a long watch even for the babies of COVID positive mothers who were born. And I think we all agree with that vertical transmission was absolutely non-significant for that matter. At least in our experience of about 635 odd newborn babies born to COVID positive mothers. And the other issue was regarding babies otherwise normal, born to normal mothers. We were isolated, we were keeping them separately, of course, from the COVID ward. But considering that our healthcare workers themselves were getting infected and incubation period, we didn't see any significant spike or even a follow-up for at least 3 to 6 months of these newborn babies coming up with significant COVID symptoms or clinical symptoms for that matter. And to be very frank, the institutional guidelines were very clear. The moment you get symptomatic, you have to drop out from the team. Yes, it can always be argued about asymptomatic and the people in the incubation period, but we didn't have any clinical, at least, or evidence-based, you can say, data to say that healthcare workers transmitted COVID infection to the newborn babies. At least they remained asymptomatic for at least 6 months to 1 year for that matter. Thank you.
So I think we've had a very meaningful discussion today, and that just proves the point that there is so much of discussion and so much of interest and so many areas of potential research and learning in the areas surrounding the direct effects and the observable effects of the pandemic, well beyond its effects directly on the mothers and the newborns, where we are directly concerned, directly into the health systems, into the mental health, into the resurgence of infections, beyond the economic effects, which are very, very obvious, infections related to issues related to waste management, issues related to handling future pandemic and calamity events. And I'm sure we are more enlightened as a group. And I'm very happy to mention here that we have had multiple participants from the Southeast Asia communities of practice here, from the 11 member nations of the WHO Southeast Asia region, and also representation from WHO headquarters, Geneva. We thank Professor Sourabh Dutta for taking part in this very enriching session and enlightening the audience. And despite the very busy schedule, agreeing to be a part of this, it's had extended by over an hour. Now it's over an hour and 20 minutes. And thank you so much. And we look forward to more interaction. This session will be put on the YouTube channel of the Communities of Practice, NQOCN Communities of Practice, after another 3 to 4 days. And all the participants can revisit these discussions and learn from it. So thank you so much, Professor Sourabh Dutta. Any last messages you would like to give to the audience before we move and end this session?
Thank you very much for the invitation, and I really thoroughly enjoyed the very lively discussion that we had. I really have no more comments. Thank you very much.
Thank you so much and have a great day, sir.